So I want to talk with you really briefly just about the latest research in terms of the etiology of the headaches that we're managing, and then really jump into what do the latest guidelines tell us in terms of how to manage patients who have acute migraine, as well as how do we manage those individuals who have cluster, who have tension headaches, who need prophylactic options. So when we look at headaches, the first thing that I think is really important to remember is that 90% of the people that walk through our door complaining of a headache, if you're in primary care or urgent care, are going to meet the diagnostic criteria for migraine. So it's 90%. We know that there are more than 28 million people in the US that are affected by migraine, and it's about 3 times more common in women than it is in men. And it tends to peak out between 25 and 55 years of age, and a lot of that has to do with the stressors that come in that point of our lives, as well as the hormonal changes that come with pregnancy, perimenopause, lactation, etc. So if you look at overall migraine prevalence, it affects about 12% of the population, yet as I told you, about 90% of the people that come in complaining of headaches are going to meet the diagnostic criteria. One of the things that's really important, as you all know, is for us to weed out those individuals who may have a secondary cause of their headaches. And I know that that is something over the course of my career that I continue to worry about every day. The reality is it constitutes about 1% of all headaches that walk through the door. Yet if you've been in the business like I have and have been treating patients for 25 years, I can count on 2 hands and 2 feet the number of patients that I've seen with a secondary headache. But there's stories that I could tell you from 20 years ago. I could tell you their story from start to finish, because those are the headaches that shake you and the ones that you don't want to miss. So it's about 1% of all headaches that walk through our door will meet the criteria for a secondary headache. About 4% of all ED headaches are actually secondary. So by far the most common headache in our population is tension headache. It's said that it affects about 80% of all individuals, but the big point I want you to take away with regard to tension is that only 4% of these people in general consult us about their headaches. So although they are by far the most common, they are very unlikely to come in and seek our care because they have options to treat oftentimes at home. What constitutes the most prevalent headache is migraine without aura. That's actually 85% of all migraine sufferers. About 15% are folks with aura, and now we are seeing an increase in those individuals who have what we call chronic migraine, and those are the people who suffer from headaches at least 15 or more times per month. Certainly cluster exists, but it's 0.8% of the population, and it's 8 times more common in men than it is in women. So I think we all know how to take a headache history, and for me, this is really the most critical, because this is really what's going to hone in on what the etiology may be and whether it's likely that what I'm dealing with today is a secondary or more worrisome headache. Now, we've all learned that migraine, or many of us learned that migraine is often unilateral, it's pulsating. That is not true. 50% of your migraine patients will tell you that the headache is located on both sides of their head, and 50% will tell you it does not throb, which is why when studies are done on people with migraine and they're asked to tell the researcher, what were you diagnosed with for headaches, many of these individuals have been misdiagnosed because there's this perception that migraines always have to be unilateral. One of the most helpful questions to ask is, tell me what you feel like after your headache is over. With migraine, people will tell you 90 to 95% of the time they feel wasted, they feel exhausted. And that's really pathognomonic for a migraine headache. Now, when we are doing our physical exam, these are really the key points that you want to make sure you are documenting and that you are evaluating to rule out those secondary headaches. Certainly, we want to check that blood pressure and make sure that they are not in a hypertensive emergency type situation. We want to look for nuchal rigidity. We want to look at their neurologic exam, particularly are they alert, are they oriented, because primary headaches will not affect the neuro exam. in general. So an abnormal neuro exam points to a secondary cause of that headache, and that's a big takeaway message. You certainly want to check cranial nerves, in particular cranial nerves 2, 3, 4, and 6 are some of the big ones to check when you're dealing with a headache. And obviously, if there's any abnormality there, you need to be concerned about a secondary cause as well. And then don't forget to check their gait. Don't forget to look at that temperature and make sure that you're not missing a secondary headache. Now, this was a criteria that was developed many, many years ago that I really use a lot in my clinical practice, and it's called SNOOP. If any one of these criteria is present, it points to a secondary headache. So my 26-year-old patient with a history of breast cancer who presented 2 years after finishing her chemo and her radiation and having a double mastectomy and a bilateral oophorectomy, who presented with headaches with a new onset with vision changes. Because she had a history of malignancy, STAT CT of the brain confirmed Mets to the brain. So you need to look for, do they have any secondary headache risk factors, such as, are they HIV positive? Are they on an anticoagulant? Or do they have any fevers? Is their neuro exam abnormal? Do they have a thunderclap presentation? Folks, remember, thunderclap headaches, that instantaneous take you to your knee headache, most of those folks go to the emergency room. However, studies have now shown that in the 2 weeks leading up to that thunderclap subarachnoid hemorrhage, these individuals have often consulted primary care with an escalation in their headaches or a change in their pattern. Under 5, over 50, unusual ages to declare a new onset to headaches. So if they're outside that age range or they're telling you my headache has changed, you have got to work it up so that you are not missing some underlying abnormality. If those of you, when you see a migraine with aura, the aura should never exceed an hour. The average aura migraine is approximately 20 minutes. So if you see an individual who tells you that they have hemianopsia, that they've lost part of their vision and it's gone on for 90 minutes, it is not an aura of migraine until you've proven it otherwise. And then certainly headaches that are associated with intercourse or with exertion or Valsalva, you need to worry that there could be an aneurysm, and an MRI, MRA may be warranted in these individuals. So this was an interesting study done by a physician where he went into waiting rooms in primary care offices and did screening tests with the patients. And he found that at any given moment in a primary care office, 37% of the women met the diagnostic criteria for migraine, and about 18% met the diagnostic criteria of men met that diagnostic criteria. That is a much higher representation than what I just presented to you. So why is that? It's because people with migraine are often affected by a lot of other conditions, including an increased risk of depression and anxiety, increased risk of seizure disorders, scoliosis, mitral valve prolapse, and bipolar disorder. Irritable bowel syndrome are all thought to be a higher prevalence in individuals who have migraine headaches. So this was a pretty interesting study done by Dr. Lipton, where he took individuals who had never been diagnosed. So these were undiagnosed migraine sufferers. And he asked them, have you ever gone and seen a healthcare provider about your headaches? And 32% of them said, you know, I have seen someone and they've told me that my headaches are tension. Remember what I told you, studies are now showing that less than 4% of the population with tension headaches will actually consult us about their headaches. So what causes people to make that mistake is often the presence of neck pain. When patients will mention neck pain to a healthcare provider, in accompanying that headache, they often leave with a diagnosis of tension headache. Yet I'm here to tell you that more than 80% of migraine patients will tell you it often begins in their neck, or they feel the pain in their neck when they have headaches, when they have migraines. So don't be confused by the presence of neck pain, because it is often present in patients before, during, and even after migraine. The other reason that often causes providers to kind of get sucked into that tension diagnosis is that stress is the number one trigger, certainly for tension, but it's also the number one trigger for migraine as well. But remember, folks, it is not when people are in the worst stress of their lives that we see most of their migraines. It's on the day that they relax, which is why Saturday is the number one day of the week. And the day after Christmas is the number one day of the year. So those are days I encourage you all not to work if headaches are not what you want to take care of. Now, in terms of sinus headaches, the American Headache Society says there's actually never been any validated headache syndrome caused by sinuses or recurrent headache syndromes caused by sinuses and sinus disease. So this was the same study conducted by Dr. Lipton. 42% of the patients reported that they had been diagnosed with sinus headaches. Yet, there's no recurrent headache syndrome that's ever been validated to be caused by sinus infections or disease. So what causes providers, again, to be confused and even patients? How often do you have people who come in and say, I must have allergies, or I get these terrible headaches every time it rains or when the weather changes? Barometric pressure changes are the 5th leading cause of migraine headaches. And people will tell you, just like my patients with OA tell me they can predict the weather by their knees, my migraine patients can tell me they can predict the weather by their headaches, because barometric pressure changes is a big cause of headache for many people. Also, when I learned about headaches, I learned that cluster patients are the ones whose nose runs, eyes water. That's not true. Migraine, 50% of migraine patients will actually tell you that they have autonomic symptoms that accompany their headache. They will tell you that their nose runs and that their eyes water and that their sinuses congest. Now, the one other issue that I want to speak about while we're talking about migraine are those menstrual-associated migraines, which are so very, very common. We also know that women now with migraine who have aura should never be put on any estrogen-based birth control pills, that estrogen is now an absolute contraindication in a woman who has a migraine with aura. And certainly pregnancy and menopause and hormone therapies can influence migraine as well. So we know that about 60 to 70% of all women who suffer from migraines actually suffer them around their menstrual cycle. And for at least a third to a half, their first migraine is going to occur around menarche. You may have seen recently that the American Association of Clinical Endocrinology has now decrease the age of normal thelarchy. It is now considered normal to begin thelarchy or breast development at the age of 7 in girls. And so because of that, we are seeing younger and younger girls who are developing their menstrual cycles because of that earlier onset to puberty. So why am I telling you about these menstrual-associated migraines? Because they're tough to treat. They tend to last 3 to 7 days. And in many of these women, it's accompanied by a lot of other symptoms, such as mood changes, etc. So here's what we now know, and this is the key to trying to help these women to prevent these menstrually associated migraines, is that we now know it's the late luteal phase drop in estriol levels that actually triggers migraine. And if you look here at this slide, you see that E2, that green line there. When that estriol level falls, beginning at around day 23 to 25 in the cycle, that is believed to be the trigger for women having menstrual-associated migraines. I tell you this because one of the things that can be helpful in these women, if they have no contraindication, is to put them on estrogen-based birth control pills and not allow them to withdraw. The other thing I do is I will start these women on a triptan 2 to 3 days before they generally have their menstrual cycle. And because that often is when those headaches occur, and I will prophylax them with a daily triptan 5 days around the time that they normally get their headache, rather than waiting for that to occur. So those are some strategies. Putting them on a progesterone-only oral contraceptive or using progesterone will do nothing, we believe, for delaying those headaches or preventing them. You really need to regulate and level out the estriol or estrogen level. So as I'm standing up here in front of you today, I want to show you the insights that we now have into migraine pathophysiology. And I want you to see this because you may have been seeing a lot of information coming out recently about a new class of medication that is going to be introduced to the market. And it is a medication that we're going to use to prevent migraine called a CGRP inhibitor. And I'm going to show you that in a second. But this is what we think is going on in the brains and of patients with migraine. So if you haven't noticed, I'm standing up here. I'm rocking heels in Coban tape and a Flector patch because the other day I twisted my ankle, and this is usually the analogy that I use when I'm actually speaking on migraine. So if I'm up here and I twist my ankle, what happens? There's an influx in blood supply. There's an influx in inflammatory mediators into that area to heal the wound. And the same happens in the brain of patients with migraine. Something triggers. There's an influx in inflammatory mediators. And you see here on this slide that there's something called CGRP, calcitonin gene-related peptide. It is a very potent vasodilator that causes blood vessels to further vasodilate. And as I mentioned to you, we've been waiting for this class to come onto the market for many, many years now. I do believe we will see this within the next year coming out as a way to prevent migraine headaches. So our brain is aneural. How is it then that we pick up this impulse of edema and inflammation and pain? Well, you can see that the trigeminal nerve is involved here. It brings the impulse down to the trigeminal nucleus caudalis, and you can see that at the base of the brain. That's where the sensation is, or the pain is perceived. But what's really important is to notice that C2 through C4 nerves actually feed into the same area, the trigeminal nucleus caudalis, which is why more than 80% of your patients with migraine will tell you they often feel it beginning in their neck, or they have a referral of pain out into the neck during their headache. It's due to the fact that these nerves feed into that same area of the brainstem. But the trigeminal nerve plays a huge role as well. You know the three branches, the ophthalmic, the maxillary, and the mandibular. Well, those branches also have a referral of pain, and that's why your patients will often tell you that they feel the discomfort in their sinuses, and they often will grab their frontal or maxillary due to the involvement of the trigeminal nerve. One last nerve to point out to you, and this is called the superior salivatory nucleus. It's a parasympathetic nerve that becomes activated during a migraine headache, and this is what causes the eyes to water and the nose to run and the sinuses to congest, which is why people are often confused, thinking this is a sinus issue, and this is why providers also become confused as well. So my big takeaway message in showing you these slides is migraine is no longer vasodilatory alone. Migraine is vasodilatory. Migraine is inflammatory. Migraine involves neurochemical releases. So what our job is to, I think, the best treatment is multimodal therapy. When I give a triptan abortively, I tell them at the same time, take an NSAID. I find that they don't need to take that second triptan and then double the cost of their migraine medications. So think about taking that medication early, think about what medications can vasoconstrict them, but also think about what can I do to block some of that neurochemical release and that inflammation. So I think we're all pretty familiar with the diagnostic criteria of migraine. This is migraine without aura, and they need two of the following: unilateral pulsating, moderate to severe, or aggravated by normal activity. And they only need two of those. And then they need one accompanying symptom, such as nausea, vomiting, photo, or phonophobia. Now, this criteria these were developed to help with a research process. But again, I think it's really helpful to be able to apply this to your patients in clinical practice. Now, the aura, as I mentioned to you, the aura generally occurs prior to the migraine. It's generally going to last under 1 hour and can be visual. It can be sensory. I have patients who smell things, who get abnormal auditory and olfactory sensations. I also have people who tell me that they have difficulty speaking. So the auras can be very different across the board. I even have patients who have a basilar migraine where their aura is vertiginous and the room spins prior to their migraine. But again, the aura in general lasts under an hour, and that's a big takeaway message. So I mentioned tension headache. What I really want to call out on this slide is on the right-hand side of your slide. They should not have any nausea, vomiting, photo, or phonophobia with a tension headache. If any one of those accompanying symptoms is present, it really does point toward migraine. And last, cluster. These are considered of the primary headaches to be the most severe of all. They are 8 times more common in men. They're often called alarm clock headaches because these are the headaches that generally wake men up about an hour into their sleep. They're also called suicide headaches because men with these headaches have a much higher rate of suicide. So they're called cluster. They last for 15 minutes to 3 hours in general, and they come in clusters, and they can be there for months and then not come back for years, but they do tend to occur in cluster. And these headaches escalate from a 0 to a 10 plus within 15 minutes. Patients will tell you their eye often waters, they sweat on that side of their forehead, and folks with cluster tend to be more agitated. This is a way to remember the differences. Cluster patients uncover and run. They tend to want to pace. They tend to want to move. Migraine patients run for cover. They want to lay down. They want to get into a dark room. They want to sleep. And that's one of the differentiating factors because these are syndromes. Tension being the most mild, migraine somewhere in the middle, and cluster being the most severe of all. And there's a lot of overlap. So I come to you from New Hampshire, and our president today said that he won our state because we are, what did he call us? He called us a drug-ridden den of society or something like that. So I come to you from a drug-ridden den of society. So this is, we just abandoned trephination. That's why I tell you that. Back in BC time, the treatment for migraine was to drill a hole in their skull to allow their evil spirits to escape. So we just gave that up. We traded that in for opioids. And now just teasing. In 1975, DHE came out onto the market, and in 1993, the triptans. Do you know studies have shown that today up to 50% of people who consult neurology for their headaches have never been tried on a triptan medication? Yet we have a lot of evidence to support these, and we have evidence that for the right people, they can be very, very effective. So they really have emerged, this along with a dihydroergotamine as the gold standard for an acute migraine therapy. The key with these products is that they were designed to treat the underlying pathophysiology and what is going on in the brain of someone with migraine. We also now know that sumatriptan injection also works very, very well for cluster headaches. That is our go-to for cluster. We use the injection over the nasal spray because it works much quicker and can actually address the underlying problem with cluster as well. So you can see here that the triptans work in 4 different ways. They prevent the they help with the vasoconstriction. They block that neuropeptide release. They're going to block the receptors on the trigeminal nerve, and they're going to prevent that central sensitization or the perception of pain. There are some additional non-pharmacologic options that are now available. Some of you may have heard of the transcranial magnetic stimulator, and this is a device that's actually placed on the back of the neck. So this is going to be for someone with acute migraine who cannot take abortive therapy, or in whom their abortive therapy is suboptimal. So they're going to place it on the back of their neck with the first onset of the symptoms of migraine. And the thought is that it helps with some of the vasoconstriction, and that what it also does is helps to prevent the neuroinflammatory mediator release. There's also a TENS unit that is available, and this is a prophylactic option. You may have seen this on the news because when this was released, it was kind of all over the media. It's a pretty interesting looking headband, but people people wear this for 20 minutes a day, and this transmits electrical stimuli to the trigeminal nerve, and we think that it makes those trigeminal nerves so that they're not so responsive in the case of a migraine. So we have both an abortive and a prophylactic non-pharmacologic option that are available to our patients. So let's go back to the triptans. The triptans are now approved down to 6 years of age. So for those of you in pediatrics, we do have a 6-year and up approval, although the prescriber's letter did come out to say a few years back that some of them can even be used safely down to 4 to 5 years of age, and that was in the prescriber's letter. But what I try to do is strategically choose the triptan based upon that patient's presentation. So for instance, if someone says to me, I wake up in the morning and I am in the middle of a full-blown migraine, I'm going to go with a nasal spray or an injectable. Because at this point, I need something to work quickly to reduce that inflammation that's going on and to vasoconstrict them. If they tell me I only get headaches in the afternoon, a pill will be just fine for them. But remember, one of the things that happens in patients with migraine is that during a migraine, they often develop gastroparesis. So these individuals will often tell you that they vomit or that they can't keep things down, and a lot of that is due to the gastroparesis that occurs during a migraine. So what I like to do is to steer clear of the old approach, which was step therapy, which was start with an NSAID. If that doesn't work, then you go to your triptan. If that doesn't work, then you go to your opioid. What I like to do now is what's called stratified care, which is choosing the medication to address the specific type of headache that the patient has and to give them options. So I have patients who often have a morning headache and an afternoon headache. I will give them both an oral as well as an injectable version. And in addition, the other thing I give them is an ondansetron or Phenergan suppository. I don't care, promethazine suppository, whichever one you like to use, but I like them to have that available. What often takes these individuals into the emergency room is their vomiting and their dehydration. So I like them to have something like an ondansetron available so that they don't vomit. And the other thing I tell them is to take an NSAID with the triptans. Couple of things about the studies on triptans. That second triptan dose has never been shown in the studies to really be an effective dose. So to take that second dose at hour 2 if the headache isn't gone only doubles the cost of migraine and has really not been shown to be a cost-effective treatment. So have them take an NSAID if they're able to with that triptan. Make sure they have something available for nausea. And there was a triptan safety committee that was done or that was convened approximately 15 years ago that actually looked at how safe is it to give a triptan to someone who's on an SSRI and how at risk are they for serotonin syndrome, and it was found that it is safe. Even though your EHRs bring up a warning of serotonin syndrome when you write a triptan or your pharmacist may call you, it is a safe option to give them. And I feel comfortable doing that. Just remember, you never give a triptan, you never give a dihydroergotamine product to someone with underlying cardiovascular or cerebral vascular disease, or a person who has a hemiplegic or a basilar migraine, because the safety of those have really not been documented. The earlier we can get people to treat their headaches, the better. The problem is many of our patients hoard their medications because they don't want to use it if they don't need to, and so they'll wait to figure out if it is a migraine. And by the time they figure it out, they're so far into that edema and inflammation that they tell you that nothing works. Now, years ago when I stood up here, I would have told you that the patient needs to take their abortive medication as soon as the aura begins. Now, some of the latest evidence is that they should wait till that aura is winding down and they're starting to feel the headache, that is probably the best time to take their abortive medication. So too much of a good thing is not a good thing. If your patients are using their abortive drug, and I don't care which one it is, an NSAID, acetaminophen, Sudafed with Tylenol, I don't care what they're using, Furoset, Furanol, more than 2 to 3 times a week, they're going to get themselves into a situation where they are developing what we used to call rebound. Many people call it medication overuse headaches. And I'm here to tell you that when they get to this point, When they tell you nothing but 100 Furacet or Furanol work for me a month, they're not lying to you, because that truly is what works for them. The problem is that they need to come off of that, because we're creating their headaches by allowing that pattern to continue. And many of us in this room have inherited people that come to us and say, 60 of these pills are what I need every month to get through the month. And my response to them, and this is the glory of feeling confident in knowing what I know now, is I say to them, I'm so glad you chose me as your provider, because I really love working with people who have headaches. However, if you wish to continue on 100 X, Y, and Z per month, you've chosen the wrong provider. So if you'd like to continue that, I'm happy to transfer your records out today. Because I am not going to continue to contribute to your Furacets and your Furanols and your butalbital, all those products that patients are taking. So it was in 2012 now that the American Association of Neurology and the American Headache Society actually got together to give us some evidence-based, prevention-based guidelines on how to prevent migraine in patients. What you're seeing here are their level A recommendations based on the evidence. We've got our valproic acid, remember Depakote. Remember that this is a category D, as in dog, in pregnancy. You do not want to use this in a woman who could become pregnant. It is a folic acid antagonist. You want to monitor liver enzymes and CBCs in these folks, but it is a fairly effective medication. My go-to is often metoprolol. I'll use the extended release and start at 50 to 100 milligrams. Evidence has shown us a 70 to 80% reduction in frequency and severity with beta blockers. But you know, and I know, people can't always tolerate those. What else do I like to use? And now for the first time ever, we now have recommendations to use nutraceuticals or to use complementary options to treat our patients. One of them is Butterbur. 75 milligrams dosed twice a day is the recommendation. And I don't know if any of you have used this, but this product may now be used in children as well. And you're going to need to change out the dosing. But the studies have shown about a 70% reduction in migraine frequency and severity. And I like this because I feel like people tolerate it pretty darn well. And so many of our patients say, I want something a little bit more natural, and I'm willing to try this. Topiramate is another one of my go-tos. Remember that generally we start at 50 milligrams dosed at bedtime. We'll move it up. I generally will max it out at 200. Once you get to 200 milligrams, it does decrease the efficacy of oral contraceptives. So those of you who are using this in women who are on oral contraceptives, once you get to 200, they need to use a backup method of contraception. The other thing about topiramate now is it is linked with cleft lip and cleft palate in developing babies. And so you want to make sure that these women are not going to get pregnant while taking topiramate, and it's now linked with kidney stones, dysgeusia, which is that taste disturbance, and the perioral paresthesias are some of the side effects. Now let's go to level B evidence, and this is probably effective. Some of my go-tos here, magnesium, 600 milligrams dosed once a day. And again, for a lot of my patients, I'll start with one, and what I expect is about a 30% improvement in their migraine with each of these products as we add it on. So I'll ask them to keep track. There are numerous apps. They can write it down. I don't care how they do it. But what I want to do is have them keep track of both frequency as well as severity. And then I will add on as we go. So for instance, maybe I'll start with topiramate, and then I'll add on magnesium and maybe Petasites or Butterbur. But these can be combined. I'm not a big fan of using NSAIDs every day to prevent headaches. I worry about that rebound, but there is some evidence that that can be helpful. The other thing you could use here is amitriptyline, particularly if these men and women are not sleeping well. I get a little bit nervous adding a TCA onto an SSRI due to serotonin syndrome. And just remember, all your TCAs have the ability to prolong the QT, and that's become a real issue in the literature. My other go-to here, there was a great study done on young women, 400 milligrams of riboflavin as a single dose once a day was shown to reduce migraine severity and frequency in young women by 60%. This is another one of my go-tos. And for patients with depression or anxiety, Perimenopause, maybe having a lot of vasomotor symptoms. Venlafaxine is one of my drugs because it blocks that norepinephrine descending pathway. And I also know that there is some evidence to support using this prophylactically in patients with migraine. Now, level C, possibly effective. I found not a lot of these to be really effective, but one of my go-tos is lisinopril. And I've had probably 10 or 15 patients over the course of my career who are hypertensive. I start them on lisinopril, and they say to me, my migraines are gone. There is a little bit of evidence to support the use. We don't really know what that's all about. People postulate that it has to do with the fact that it's preventing the release or production of Ang2, which is a potent vasoconstrictor, but none of us really know its mechanism of action. But again, the evidence is level C here, possibly effective. CoQ10, 100 3 times a day, that's a pretty good dose, and it's also an expensive dose. And I've not found a lot of benefit to it, but it's another option. One of my go-tos in kids is cyproheptadine. Cyproheptadine, as many of you know, is an antihistamine. We'll dose it 2 to 4 milligrams a day at bedtime. And for some kids, it can be really helpful. It is safe to use. In kids, you probably know of this as Periactin. I'm sure you've heard of that drug. And we will dose this at bedtime. The biggest side effect for this is sedation and potentially weight gain, so you want to watch those kids closely. Now, I told you about some of the other ways to prophylax people who have menstrual-associated migraine. You can put them on a triptan. For the 5 to 6 days around their menstrual cycle on a scheduled basis, 2 to 3 days before and then a couple of days in. You can see here in the guidelines they said frovatriptan 2.5 twice a day perimenstrually. Naratriptan and zolmitriptan are probably the best evidence out there when using a triptan to prophylax people. So let's now talk about cluster headaches. The best abortive treatment is sumatriptan injection, and the studies have really borne that out recently, along with oxygen. We will set these individuals up to have O2 at home. We'll ask them as soon as it comes on, put 7 liters of O2 via high-flow oxygen mask, and give yourself a sumatriptan injection. Prophylactically, I don't know if any of you have ever done this, but I have 3 patients in my clinic now who swear that I am the best thing since sliced bread. They had cluster headaches. I started them on 300 milligrams of lithium, and they haven't had a headache in years since we started. Please remember that lithium has a narrow therapeutic index, and you can't use lithium with hydrochlorothiazide. There's a contraindication in the kidneys, but this is a great option and the best studied option to prophylax your patients with cluster. So I want to wrap up with the people that you and I think of when we think of our hardest to treat patients in our clinic. These are them. These are the patients who have what we call chronic daily headaches. They have 15 or more headaches a month. They tell you that there isn't a day in general that goes by that they don't suffer from a headache. And certainly we need to work out, is it a trigeminal neuralgia? Do they have a hemicrania? Many of these folks actually have chronic migraine. And many of them have these headaches as a result of overusing their medication. When we look at the population in headache clinics, of which there are very few in my community and very few people who really want to take on headaches, 30 to 80% of the population that attends a headache clinic are actually folks with chronic daily headaches. So this is really the biggest group of individuals. I had the ability to go out to Ann Arbor, Michigan about 15 years ago and train in an inpatient facility where the average patient there went there and spent 11 days to detox off of all the drugs that they were put on out in primary care. And once those drugs were taken away, then they were able to then re-add in a systematic manner. But a lot of what happens and what causes these people to do what we call transform their migraine is that they are way overusing their medication. So again, the rule is 2 to 3 times a week is going to set them up. When we look at chronic daily headaches, who has them? About 60% of people have them as a result of the medications they're taking. So what are they taking? They're averaging about 5 pills a day. And if you add this all up, this totals way over 100%, and that's because they're combining butalbital with an opioid, with an aspirin, with a triptan, with acetaminophen. But you can see that patients who have medication overuse headaches are averaging over 5 pills of something a day. And unless you and I break them, they're not going to get better. So, when do we see this medication overuse? Here's the general rule. 10 or more triptans, ergotamines, opioids, butalbitals, 10 or more of any of those combinations, we're going to start to see overuse. Any other analgesics, such as NSAIDs and acetaminophen, it's about 15 days of use. And triptan overuse is more likely to increase migraine frequency. So what do we need to do with these folks? A, we need to treat the underlying comorbidities. Many of them have depression, many of them have anxiety, so strategically choose your medications, such as an SNRI, that is going to give us some blockade of that norepinephrine pathway, but at the same time may actually help to benefit their migraine. We need to set limits on their abortive drugs, and if they can't do it, I will do it for them. If I have to give them a week at a time, that is what I will do. And I will ramp up non-pharmacologic therapies, including acupuncture, acupressure, exercise, physical therapy, TENS units, etc. So one of the things I do for these folks to help try to break them out of this cycle is I use prednisone. This is one of the few times in my career that I really taper prednisone, but I will start them on up to 1 milligram per kilo per day, and I will taper them down off of the prednisone over 21 days. This is to prevent that inflammatory mediator release that I spoke about earlier, and at the same time I'm putting them on prednisone, what I'm also doing is ramping up their prophylactic meds, and I'm decreasing the meds that they're overusing. So how am I doing that? I'm doing it 10 to 25% per week. So for instance, if they're taking 60 butalbital, so I've got them on prednisone, I'm starting that today. If they're taking 60 butalbital a month, that's about 15 pills a week. I'm going to go down by about 10 to 25%, so that's 1 to 2 tablets a week, which means this week you get 13 pills. Next week you get 11, and we go down from there. It often takes me a good 3 months to get these people off of what they are overusing, and it requires a lot of care and comfort, and it requires a lot of dedication on your part. Because I'm here to tell you, they're going to write you on the portal every single day. They're going to call you every single day, and you've got to be their cheerleader, and you've got to be committed to the fact that we are taking you off these medications. My friend Josh owns a pain clinic. When someone breaches a pain contract with him, he takes them off 25% a week. So I know that 10% is a slow taper for these meds, but I can go as high as 25% and do it safely. So what are we going to do to control their pain? Well, I've got them on prednisone, but that may not control their pain. So what am I going to do? I'm going to use things that they're not overusing. So for instance, if they're overusing an NSAID, butalbital, I may use a triptan to help abort those headaches. I might use hydroxyzine. This is one of my go-tos to help them to sleep and also help them with the anxiety. But the key is you want to use medications that they're not using and overusing. So this is the diagnostic criteria for chronic migraine, which is 15 or more days per month for 3 months or more. And when it first began, it was your classic migraine. But what happens is over time, because of the overuse of their medications, the headache loses its acute type of presentation, and they get into this everyday low-grade headache that waxes and wanes but never goes away. The other thing we have now introduced in our clinic in the last year is we use medications such as Botox or Dysport that are indicated for the treatment of patients with chronic migraine. And what I will tell you is, from a teaching perspective, patients need to be told that they are not going to notice any improvement in the first 3 months. That in general, it takes 2 cycles of these injections before we're going to be able to notice improvement. And their headaches are not going to completely go away, but what it's going to do is it's going to bring the severity down, and it's going to drop frequency. And it's going to make them respond to our abortive treatments better. So the units that we use vary depending upon the patient, but this is where we will place this injection. You can see we do the forehead, that's some work on that trigeminal branches. We do the temporal region, and then in the occiput, and then down into the upper shoulder, neck area. And again, takes about 6 months before we really start to see benefit. And a lot of times my patients will say to me, there was no benefit to this. And then they get to that 6-month mark where it's wearing off, and they'll say, holy cow, this really is working. So again, don't abandon it on the first try. Give them a good 6 months of the trial. The problem for me is trying to get this improved is through their insurance company. It's really requires a lot of effort on a lot of people's part. And it takes my staff hours to try to get this approved. So what about the patient in my last minute who walks into you and says, I am 3 days into this headache. I cannot break it. What we do in our clinic is, in a way, to try to keep them out of an emergency room, what we will do is we will use ketorolac, 30 to 60 milligrams of ketorolac in the office. You know if this is Toradol. I'll give them an ondansetron or Phenergan suppository at the same time, and I'll give them a liter of fluid because by this point, this individual is often really dehydrated. They've had such gastroparesis that they're not eating or drinking. So I'll give them some fluids, and then I will send them out tomorrow on 60 of prednisone, the day after 40, and the day after that 20. And what we've found is we've been able to break about 90% of our acute status migrainosus patients with this type of regimen. Other offices use subcutaneous sumatriptan, and there's now a breath-activated sumatriptan. I don't know if any of you have seen this, but it's a nasal powder that we keep in the office. The patient blows into the device, and it deposits the powder into the nose. That's another option that is available that we have in our office. But a lot of what we use is the injectable NSAIDs, such as ketorolac. We found that really, really helpful. So I hope that this has been a helpful 45 minutes speaking about migraines and other headaches with you, and I'll be back to join our panel later this afternoon for any questions that you may have. Thank you so much for joining me.